usually see them before they get ready to go back to work, just to make sure that all their questions are answered. And we've reviewed again what they should or should not be doing, right? And and at 6 weeks is usually when people come in and say, well, I'm not feeling so exhausted anymore. When can I start exercising? When can I start having sex? These things. And it is, nobody follows a cookbook. So I like being able to find out what the patient needs. What does exercising mean to you? Are you want to jump back into 2 hours of CrossFit a day? No.
Yeah.
Let's talk about how you can get yourself safely back.
Right.
Does exercising mean that you want to walk around the reservoir? Well, think about feeling exhausted halfway around the reservoir. How are you getting back? Right? So why don't you start by walking 20 minutes in a circle around your house where you can sit on the curb and somebody can go get the car and get you if it hits you that you can't take another step. So it varies from patient to patient. I generally want people to not travel too far away from me in at least the first 2 weeks, if not the first month after surgery. I always say to I'm protective, I'm possessive of my patients, and most people are not going to a place where there is no medical care, but I don't really want you ending up in somebody else's emergency room, right? I want you to be in a place where if you need to be seen, I can see you.
Yeah. Right. Yeah, that's so great. And it is, everyone's so different. Like you said, there are people that want to get back to CrossFit, and there's the people that want to do other things. Like, everybody's so different.
The patient that we had in common, is very physically, she found you. She's very physically active, and she was like, well, I just want to get back to this. And I said, okay, so let's do the 10-10-10 rule. Okay, that's my rule. You do 10 minutes of activity at 10% of the intensity you were doing, and then you take a personal inventory for 10 minutes after you stop that activity. And if you caused increased discomfort that persists for more than 10 minutes, you overdid it.
Oh my God.
If, on the other hand, you feel fine, then do 20 minutes the next day, and then do that still at 10% intensity, and then do your 10-minute check-in. And patients can get back to work easily and safely after that. Because the last thing you want to do is injure yourself or put yourself back a couple of weeks in your recovery process by overdoing it.
Right. Oh my gosh, I love that. Because like you said, when we don't want to do that. We don't want to do 10 minutes of 10% intensity.
Right. Right. Exactly.
You don't want to.
Exactly.
It's the best advice.
Yeah. I know. Well, because listen, if you stop exercising for 3 weeks, you can't go back to the routine you were doing. You've lost some of that, and now you have a surgical thing that you have to protect. Okay, so can I go get my charger, my charging cable again? I'm so sorry. I'll be right back.
No problem.
What'd you say? Is it okay?
Yeah.
Okay, I'll be right back.
Thanks.
Hi. Sorry, I'm doing a webinar.
Hey guys, I just stopped the other live because I was going to lose it because it had been an hour and I restarted this. So if you're on the other one, we're just continuing for a little longer.
Okay, I am back with you.
I love it. All right. Now, I heard from our mutual client, she was saying something that you were having her doing some breathing after surgery.
Yes.
I was like so excited.
Yeah, because you have to be able to get those muscles to work again.
Sure.
So it's really difficult to do that after years of their not remembering how to work. So I always explain to patients that, we don't think about the 46 muscles involved in synchronously relaxing and activating as we go to reach for something to get our fingertips in the right area. Right. Our brain does that for us. And as the brain is doing this, it's automatic. But if we have muscle dysfunction, like rectus diastasis and a whole disruption of the abdominal wall, we forget how to use those muscles and the brain doesn't do it again properly. Combine that with the fact that once you don't like how bulgy your belly is, you walk around holding your stomach in all the time.
Right.
You have now disrupted the use of those muscles and the way you breathe. So typically what will happen is, as patients are feeling comfortable enough to start doing this, and that again varies from patient to patient, I will say to patients, I don't know if you can see my shoulders here, I will say to patients, take a deep breath, and they take a deep breath and their shoulders go up and their stomach comes in, and that's what they're doing, and they have completely forgotten how to belly breathe. So I don't really know where I learned this. I don't think anybody ever taught it to me. It just made sense. So I teach them, the first step is to learn how to breathe with your belly again. And that involves letting go of the fact that you've held your stomach in for all this time.
Yep.
And so you have to take I have them stand and look in the mirror, because I want them to do two things. I want them to hold their shoulders still.
Yeah.
And I have them put a hand on their belly, and I say, push that hand away with the breath. And it's amazing how few of them can do that.
Yep.
So that is what I give them to practice at home, right? You just need to be able to do this. And so that's the first step. The second step, after they've got that belly breathing back in, I think that there's a technique to get them to engage their rectus muscles again. And that involves taking that big belly breath, and then as you exhale, envisioning anchoring your ribs to your pelvis and bringing your belly button towards your back. Okay. And that starts engaging the rectus muscles again. And it's doing it without there being any kind of weight bearing stress on it. It's just teaching them how to work again.
How to feel them again. Like, oh, there they are. And you know.
Right. Exactly. I don't do any personal training, and I do have some people who do, who I can send patients to, but I really find that most people get back to their activity just with being able to learn how to breathe again, and then how to breathe, exhale, and engage that rectus muscle.
Yeah. Well, this is what I do with a lot of my pregnant women, postpartum women after having a baby in there, even if they don't have, an issue with diastasis per se. But all that area ties in the pelvic floor, and where they're holding their breath, and in their how they're holding tension. I mean, it's like the whole thing, right? And so that's often like people are like, oh, and trying to get them to relax their bellies and like everything. And they're like, wow, this is so hard. I've never done this. So when our mutual client had said, oh, she had me breathing, I'm like, who is the surgeon?
I love it. I love it.
Because it's a thing, right? Like, it's just a thing. And it's simple, but it can set people off with that, just being able to move again and feel better. I mean, really, all it is. Right. To feel better. Cool. All right. Recovery. We got compression. Man, we think we covered a lot.
Wow.
We're good.
I like talking to you.
Me too. Oh, so this is the other thing I'm asking everybody, because this is a thing. So when we talk about, and you were talking about the flatness, and how, washboard, like women are, this is a tricky thing being flat, because like you when you eat food, you can bloat, or, I don't know, you eat fast, you're inhaling air, or like, you eat pizza or whatever it is, right? And so there's a difference between just distending because you've eaten a big meal or something, versus this repair has failed, versus this is swelling that can last for a year, or and it gets all kind of mucky, and everyone's kind of not sure where that's at. So how do you explain that to clients?
Well, I will tell you that patients who have intra-abdominal fat are always going to have round abdomens. Okay, it doesn't matter. I can make them temporarily flat, but that is going to stretch out, and tissues stretch. It doesn't mean that the repair fails.
Got it.
So I have become more interested in some nutritional lifestyle counseling. And I will discuss this with patients before I do this. You know, I will put them in the mirror and say, in front of the mirror and say, you know, this is what's extrinsic and this is what is inside your abdomen. And no repair I'm going to do is going to correct that.
Yeah.
I do think that with absorbable sutures, then you can physically get a separation of the repair. And again, that's why I use the permanent stitches. A lot of people use absorbables, and I just don't.
Yep.
I can honestly say that I am not aware of ever having had a rectus repair failure. Okay. I do have patients who really need to work harder than some others to get the rectus reactivated. Okay. It doesn't matter how tight you pull that together. If the muscles are not active, then you still have a floppy abdominal wall.
Sure. Yeah. And just strengthening them and being able to, and that's why I really try to get out to women doing like almost a prehab for surgery too. Even with it being funny, like, you know, and I was able to kind of figure that out. And it takes a lot of work for a while, but I had a great physical therapist and all this stuff. And then that way you can go in a little bit stronger. And then when I came out of surgery, I went back and did some of that rehabby stuff that I'd done before. And I remembered how to do it. So it was so much less overwhelming because, you know, you're so disconnected after that surgery. Right. But I could kind of do those subtle things and I could start to feel my rectum. I'm like, oh, okay, all right. And it wasn't as overwhelming because I had done it before.
Right.
And I think that I mean, you're speaking a lot to that. My surgeon spoke a lot to that. I want women to get the support before and after the surgery. And you do such a good job because you're seeing the patients so much and checking in with them. And I can see how that's more so than a lot of other surgeons. I think that probably makes a huge difference. But women need more support than they want to admit, or they're even
Right.
And huge parts to it, you know?
Yes. And, you know, and I always tell patients that their overall outcome is probably only, you know, 20 to 30% how fabulous I am in the operating room.
That's exactly what my surgeon said. Oh my God.
You know, the recovery is the biggest part of it. And that's really on them. I can coach, but I don't go home with them. Yeah. And if, you know, so I want to engage the patients in being very active in this process, because it doesn't work as well. There's so much more to just what's done in the operating room. So I can sew everything back together. You have to learn how to use the muscles.
Yes.
Right? You have to eat well.
Yeah.
You have to be kind to yourself and sleep enough. You have to know when to call with a question, right? I always tell patients, there's no such thing as a stupid question. And I would much rather have a conversation with you over the phone where the end result is, yeah, that's okay, we don't need to worry about it, than to have you at home with a real problem that I don't know about, right? And that I can't help you with.
Right. Yeah. Yeah, it's hard. It's tough. I had so many questions and it's hard, but oh my gosh. Well, I think, oh my gosh, we did it. Just over.
Yay.
Any final advice or words of wisdom from all your years of doing tummy tucks?
I really think, again, it comes back to what we talked about in the beginning. This is a relationship by choice. And the surgery is a cosmetic surgery. I do think that you will feel better, but it's elective. And so you need to take the time and form a relationship with somebody who you trust to help you get through that process, who you can engage with and really partner with. Because if you're not comfortable with that surgeon, your recovery is going to be harder.
Yeah. Oh my gosh, this was awesome. Great.
Yay!
So helpful. This is my project.